Okay, so the next devices are the nebulizer. This is a small volumetric nebulizer. It basically delivers medication to our patient that they can breathe in. It goes into the lungs and it's supposed to help open up the lungs a little bit to allow them to breathe better. We usually put the medication in through the top. The gas from the oxygen tank goes through this device, causes it to mist up. That mist then accumulates and the patient is able to breathe this in. To set this up, we usually have some tubing, corrugated tubing, and a T-piece. Acorn, T-piece, corrugated tubing, and usually we have what's a little bite block where they kind of bite down on it so that they can breathe into it. And then we have our oxygen tubing that goes to the base of this. This will be connected up to oxygen, and we want the liter flow rate of 6 to 8 liters only. 6 to 8 liters. Anything less than 6 liters is not going to cause this thing to mist at all. Anything more than 8 liters is going to cause too much misting, and the size of the microns, those drops, are going to be so fine that it's not going to be able to go down into the lung and stay in that area. So 6 to 8 liters. Again, we'll connect this up to oxygen, and again the rate is 6 to 8. We have all our pieces together. We didn't turn our oxygen on. We're going to take the medication, twist off the top and squeeze it in, twist off our top and squeeze it in, twist off our top and squeeze it in. We're usually giving albuterol and atrovent. We put the T-piece on. We'll go ahead and turn this up to 6 to 8 liters, and then we'll give it to the patient so that our patient can breathe into this, and the mist and medication aerosolizes here. It'll start coming out. When they take a breath, all of this medication goes down into their chest, into their lungs, and when they breathe out, it goes back out and it continues to mist. So this is where it's all collecting when they take in the breath from this medication. Now in some cases the patient can't hold it, they can't tolerate holding it in their mouth, it's too hard for them. We would just take off the T-piece, the corrugated tubing, and would attach it to a mask. In some cases we have a type of mask which has 2 holes here to allow them to breathe through it. Because they're having trouble breathing, we don't want to obstruct that, so they can breathe in air as well as the medication that's also accumulating in this mask. So it allows them to breathe the air in and out. If for some reason you are getting this ready and your patient's already on a non-rebreather mask, we just yank the reservoir bag off, remove it from the patient, connect up our acorn to the bottom of this, plug this back in, and you can remove the other partial seal on this so that they can breathe. It works just like a mask for a non-rebreather, for a nebulizer treatment. So again, the nebulizer treatment, usually we use an acorn, the T-piece, corrugated tubing, and a bite block. Medication is added to this, 6 to 8 liters. They can't tolerate holding this. We can place this onto a mask, which usually comes like this, or we can use a non-rebreather mask and just take it off and then connect up. Should our patient not tolerate and become more hypoxic, and we're going to have to ventilate them with positive pressure bag valve mask ventilation, we may need to connect this up to our T-piece. So that we can give it to our patient, excuse me. So we can connect this up to our patient. We take the corrugated tubing, the T-piece, and the acorn, and we remove the bite block, and all we do is connect this up to the patient mask now. And usually so they're sitting upright so that the acorn remains in an upright position, and we can ventilate and give every breath we're giving medication. The only part now is we're connected up to oxygen here, and we're connected oxygen at the acorn. We need 2 oxygen ports, and we're running this at 10 or 15 liters or more. And how many liters are we running the acorn or nebulizer at?
6 to 8.
So this is one way that we can positive pressure get medications in. And in some cases we may end up having to place a breathing tube down into our patient. When this is put into the patient, We'll connect up our T-piece again. And this breathing piece is down into our patient. Here we have the medication welling up from inside this misting acorn. As we ventilate the patient, the medication is pushed down into the breathing tube and down into the lungs. It would require us to have 2 sets of oxygen administration, one at 6 to 8 and one at 15 liters or more. When we need to change out and add more medications, we're going to have to shorten the T-piece so that we can ventilate them while we refill this. As you refill this, you either turn off the oxygen, kink the tubing, or remove the tubing from the acorn so when you can put more medication in. Again, albuterol atrovent, or albuterol itself, or albuterol and atrovent, that's a dual neb. We'll add the medication in on the top. If you were to keep this connected up to oxygen and you put the medication in, it's going to shoot back up in your face. So that's why we remove it from oxygen, we kink the tubing, or we turn it off, place our medication back in, connect up back to oxygen, turn everything back on, connect back up to our T-piece, and continue to ventilate our patient, giving our medication through the nebulizer. Alright, that's it.